Thank you all for joining our meeting this morning. The topic for our presentation will be Meniere's disease. My consent was obtained from the patient, and all my content is referenced. So my patient was a 72-year-old male who presented with a 4-year history of intermittent vertigo lasting a few hours, progressively worsening left-sided hearing loss, non-pulsatile tinnitus, and occasional oral fullness. Well-controlled hypertension on enalapril and amlodipine, no surgical history or trauma of note, no allergies. He was a pensioner, lived alone, and he does trophy making as a hobby. He does not smoke or drink alcohol, and he consumes a low-salt diet. On examination, he was well-looking. There was no facial nerve palsy. There was no nystagmus. Otoscopy was normal. The tympanic membrane was intact and non-retracted. Pneumatic otoscopy was normal. Weber was central. Rini was positive bilaterally, and head impulse testing was negative bilaterally. An MRI was done, and retrocochlear lesions were ruled out. An audiogram was done, which showed a left-sided severe to profound mixed hearing loss and a right-sided normal to severe mixed hearing loss. In terms of management, there was no improvement with beta histine from private. Intratympanic injection of gentamicin in OPD failed. The patient was therefore booked for an EUA in OT. A tympanomeatal flap was raised. Tenotomy was done for tensor tympani as well as for stapedial tendons. Adhesions were released around the oval window, and 80 milligrams of gentamicin was instilled for 10 minutes, and a T-tube was inserted. The patient was reviewed 1 week later in OPD. He reported that the vertigo attacks had resolved, and he was given a 2-month review date. So my presentation this morning is on Meniere's disease. Meniere's disease is an idiopathic inner ear disorder that is characterized by recurrent spontaneous vertigo, accompanied by fluctuating or progressive sensorineural hearing loss, tinnitus, and oral fullness in the affected ear. Initially, it usually afflicts one ear, but both ears can be involved. The prevalence and incidence vary according to the ethnic background and the region in the world, but range from 3 to 513 per 100,000 individuals. The condition has an average age of onset of 30 to 50 years, and it rarely affects children. Onset in older people is rare, with just 10% of patients showing disease onset after 65 years. Its prevalence increases with age. The distribution of Meniere's disease by gender is variable, depending on the demographic database. Although unilateral Meniere's disease is more frequent, bilateral Meniere's disease increases with duration of illness, and up to 45% of unilateral Meniere's disease patients will develop contralateral disease over time within a 20 years follow-up period. The condition is associated with endolymphatic hydrops, which is caused by the accumulation of endolymph, resulting in enlargement of the endolymphatic space of the inner ear. The increase of the cochlear duct pressure damages the organ of Corti and other inner ear membranes. However, endolymphatic hydrops itself does not explain the attacks of vertigo, since histopathological studies have reported endolymphatic hydrops in individuals without Meniere's disease. The inner ear changes leading to symptoms may be caused by a range of pathologies. They include autoimmune diseases, allergic responses, obstructed endolymph drainage, excess endolymph production, autonomic imbalances, viral infections, dietary deficiencies, and vascular irregularities. The polyganglionitis episodica theory is one of the theories of Meniere's disease. It postulates that the herpes simplex type 1 virus is the root cause of Meniere's disease and that it explains all the symptoms of Meniere's disease. There is a comprehensive review from the Ear, Nose and Throat Institute of Johannesburg on the topic. The herpes simplex type 1 virus stays in the nerve cell body for life in infected persons. It is usually dormant and is only awakened by stress in the host, which causes the virus to replicate and attack the parts that are supplied by the affected nerve. In some patients, it may be the cochlea with hearing loss and tinnitus, and the vestibular organ with vertigo. There is also an interesting article by Gesek published in 2009 that postulates that Meniere's disease is a viral neuropathy with vertigo control achieved in 91% of Meniere's disease patients by means of a cyclovir treatment. The middle ear muscle theory is another theory that postulates that Meniere's disease is caused by the abnormal and sustained contraction of the tensor tympani muscle in the middle ear. The sustained inward displacement of the stapes causes sustained increased inner ear pressure with compression of the outer hair cells and the generation of the symptoms of Meniere's disease. And the reason for this is unknown. 5 clinical subtypes of Meniere's disease are described in the literature. Type 1 is classic unilateral Meniere's disease with metachronic sensorineural hearing loss in bilateral Meniere's disease. Type 2 is delayed unilateral Meniere's disease, also called delayed hydrops, with synchronic sensorineural hearing loss in bilateral Meniere's disease. Type 3 is familial Meniere's disease in both uni and bilateral Meniere's disease patients. Type 4 is migraine and Meniere's disease in both uni and bilateral Meniere's disease patients. And type 5 is autoimmunity and Meniere's disease in both uni and bilateral Meniere's disease patients. Meniere's disease develops in 3 phases. In the initial phase, vertigo is the most important symptom, which is considered the beginning of the disease. Less than 30 patients make their debut with the classic triad, and there is usually a latency of 1 year from the onset of auditory symptoms to complete disease development. The hearing loss progresses and fluctuates and usually affects the low frequencies the most. The tinnitus becomes louder and eventually permanent. The vertigo disappears, sometimes leaving a residual feeling of dizziness or unsteadiness as vestibular hypofunction ensues. The active or intermediate phase has an average duration of years. The sensory neural hearing loss progression starts greater at low frequencies with a fluctuating course. The vertigo persists with a tendency to decrease with remission periods of up to several months. And in the final phase, patients usually do not describe actual vertigo, but more commonly feelings of imbalance. Meanwhile, the hearing loss becomes permanent and progresses with persistent tinnitus. So tinnitus can be one of the most disabling symptoms in Meniere's disease, together with vertigo episodes. In many cases, tinnitus is the initial symptom of the disease and can precede the classical symptoms of hearing loss, vertigo, and oral fullness. The tinnitus is commonly described as a low-frequency tone and usually is a narrowband noise described as a roaring or machine-like sound. At the beginning of the disease, tinnitus is intermittent and appears during vertigo attacks in 83% of patients, disappearing after the acute crisis. And as the disease evolves, tinnitus may become permanent, although changes in the tinnitus frequency or intensity can be perceived before or after the crisis. In the last stages, when episodes of vertigo have disappeared, tinnitus becomes the predominant symptom, being the main cause of disability in Meniere's disease, and causes a significant deterioration in the perceived health-related quality of life. So the following clinical findings have been described with Meniere's disease. Drop attacks, also called to-marking crisis, are acute episodes of sudden collapse without loss of consciousness. They are forewarning or focal neurological symptoms. It can be followed by vertigo or instability. It is believed that it might be due to an abrupt distortion or discharge related to the macula of the utricle or saccule, producing a loss of verticality references. They are more commonly observed in bilateral Meniere's disease. Then we've got the Lamoyer's syndrome, which is a rare Meniere's disease variant in which during a vertigo crisis, the patient reports hearing improvement and the hearing loss progresses slowly. We've also got partial syndromes, which involves hearing loss without vertigo, which is cochlear Meniere's disease, and vertigo without hearing loss, which is vestibular Meniere's disease. And these are considered incomplete phenotypes frequently observed in familial Meniere's disease. Lastly, we've got delayed Meniere's disease, which consists of Meniere's disease with vertigo in patients with previous severe to profound sensory neural hearing loss, occurring many years, up to 50, after the development of the hearing loss. A clinical evaluation is indicated when Meniere's disease is suspected, and that should include otoscopy or otomicroscopy, cranial nerve examination, ocular motor examination, including saccades, smooth pursuit, vergence, and vestibular ocular reflex, and head impulse testing, also Romberg and gait testing. The evaluation of the auditory status of the patient is important, both in the diagnosis and follow-up. Audiometry is the most useful test for Meniere's disease. A pure tone audiogram should be performed in all patients with an episodic vestibular syndrome. In Meniere's disease, the demonstration of hearing fluctuations at low and medium frequencies during vertigo attacks is required for the diagnosis. And to show this fluctuation, hearing thresholds must be tracked over time. Verbal audiometry must be performed for speech perception evaluation in patients with sensory neural hearing loss, tympanometry for the evaluation of the middle ear status and to rule out otitis media with effusion, acoustic reflexes to evaluate the reflexive contraction of the stapedius muscle, and this gives information about the vestibular and facial nerve function. Otoacoustic emissions to measure the sound generated from the outer hair cells of the cochlea, and this can be considered in selected patients with Meniere's disease. And lastly, electrocochleography, which is an electrophysiological record of the cochlear function. It has variable sensitivity and specificity in patients with a clinical history consistent with Meniere's disease. Vestibular function tests help to confirm the vestibular hyperfunction obtained after the first physical examination of the patient. Caloric testing is an objective test that is used to demonstrate peripheral vestibular dysfunction, and it is based on oral stimulation with different temperatures to evaluate horizontal semicircular canal function, and it can confirm unilateral vestibular hyperfunction in up to 75% of unilateral Meniere's disease cases. Then we've also got VAMPS, which is a test that uses cervical ocular muscle reflexes evoked by a loud noise in the ear or high frequency vibration, which helps to evaluate the function of the saccule, so CVAMP, and utricle, the Hervin. Its role for Meniere's disease diagnosis is so far unestablished, with a sensitivity of 50% and a specificity of 49%. And lastly, we've got video head impulse test, which is an objective measure of the vestibular ocular reflex for each semicircular canal. The vestibular ocular reflex gain is used to track vestibular function during follow-up. The following is a list of non-specific tests that can be used to evaluate vascular risk factors, thyroid dysfunction, or autoimmunity. And these tests include hemogram and an ESR, biochemistry, bloods for the determination of autoantibodies, serology to rule out some infections such as HIV, syphilis, CMV, toxoplasma, and mycoplasma, Western blot for the detection of serum antibodies against cochlear antigens, and flow cytometry for lymphocyte subpopulations of peripheral blood. The clinical utility of MRI for the diagnosis of Meniere's disease is currently under debate. The visualization of endolymphatic eye drops is not required to define Meniere's disease, and MRI imaging should not be used to replace the diagnostic criteria of Meniere's disease when all definition criteria are fulfilled. Furthermore, endolymphatic eye drops is not a specific finding in Meniere's disease. The 2015 diagnostic criteria for Meniere's disease considered two categories. So firstly, definite Meniere's disease, for A, which is basically 2 or more spontaneous episodes of vertigo lasting 20 minutes to 12 hours. B is audiometrically documented low to medium frequency sensory neural hearing loss in one ear, defining the affected ear on at least one occasion before, during, or after one of the episodes of vertigo. C, fluctuating oral symptoms, which involves hearing, tinnitus, hearing loss, tinnitus, or fullness in the affected ear. And D, not better accounted for by another vestibular diagnosis. And secondly, we've got probable Meniere's disease, which consists of 2 or more episodes of vertigo or dizziness lasting 20 minutes to 24 hours. B and C are the same as for definite Meniere's disease. In the treatment of Meniere's disease, we need to consider an effective treatment for the vertigo attacks and to prevent future crises. A flexible management strategy needs to be formulated for each patient and for different stages of the disease. Treatments are best considered from a symptom control viewpoint, leading to a stepwise introduction of available therapies depending on their toxicities and ease of administration. The objective is to reduce the intensity of symptoms. Lifestyle adjustments like rest, avoiding sudden position changes, and hydration have been recommended. During acute vertigo attacks, patients can benefit from vestibular suppressants. The most frequently used drugs are benzodiazepines, H1 antihistamine receptors, antidopaminergic agents, anticholinergics, and antiemetic 5-HT3 antagonists. These treatments should not be prolonged beyond 48 to 72 hours, as they may delay vestibular compensation and produce side effects. Preventive strategies seek to delay the development of new vertigo crises and recover the functionality of the inner ear. Dietary modifications include dietary measures such as avoiding caffeine, tobacco, alcohol, and maintaining a low sodium diet with abundant hydration. Also, lifestyle changes such as avoiding potential triggers such as stress and sleep deprivation. The use of corticosteroids is mainly supported by the high prevalence of autoimmune disorders and the role of the innate immune system in inflammation in the pathophysiology of Meniere's disease. Corticosteroids have immunosuppressive, anti-inflammatory, and vasodilator effects. And also they also have theoretical neuroprotective effects, but there are no randomized controlled trials showing any benefit from oral steroids in Meniere's disease in the long term. Most diuretics reduce extracellular volume, which is supposed to decrease endolymphatic pressure and volume, either by increased drainage of endolymph or a reduction in its production at the stria vascularis. But the evidence supporting their efficacy is scarce. The use of beta-histine is based on its antihistaminic and vasodilator effects in the inner ear, specifically at the stria vascularis of the cochlea. Beta-histine could reduce the number and intensity of vertigo attacks, producing symptomatic improvement, although evidence supporting this results are low. The BMED trial in 2016 showed no benefit compared with placebo, but regression to the mean and heterogeneity of Meniere's disease patients may partially explain the lack of benefit. The effects of beta-histine are dose and duration dependent. The standard dosage is 48 to 96 milligrams per day, although a higher dosage between 288 and 480 milligrams per day is sometimes used. Beta-histine is fastly metabolized by monoamine oxidase AB. In this sense, selagelene, an inhibitor of monoamine oxidase B, increases the plasma biodisponibility of beta-histine, and thus in combination with beta-histine and selagelene, that could be an alternative to a high dose with beta-histine. Equally, an intranasal formulation of beta-histine called AM125 is currently being investigated to bypass the effects of first-pass metabolism found with oral intake, and thus increasing beta-histine concentrations in blood. The use of positive pressure generating devices, such as the Meniere device for Meniere's disease, is discouraged. These devices deliver small pressure pulses to the inner ear via an earpiece placed in the external ear canal. A tympanostomy tube placed in the eardrum allows the micro pulses to enter the middle ear space, where it can then transfer the pressure to the inner ear, resulting in a displacement of excess inner ear fluid, that is in the endolymph, and that theoretically results in normal inner ear pressure. The optimal frequency for using the device is 3 applications of the pressure daily for at least 6 weeks. And if there's no improvement in vertigo after 6 weeks, then it is unlikely that the device is efficacious for a particular patient. In case of lack of response to the previous options, the next therapeutic step is to consider intratympanic treatment with different drugs. Intratympanic corticosteroids have been classically administered to obtain a more localized anti-inflammatory and vasodilator effect in the ear, and it has been considered as the first option of intratympanic therapy, since the side effects associated with this therapy, like hearing loss, chronic symptoms of dizziness resulting from fixed vestibular loss, or other adverse effects are very low. And finally, in case of failure of conservative therapies, intratympanic gentamicin can be used to induce a partial chemical labyrinthectomy. The aim is to greatly reduce hair cell function in the vestibular system of the affected ear. Gentamicin is relatively vestibular toxic, but leaves the cochlear hair cells intact, making it suitable for treatment of intractable vertigo in ears with functional hearing. Gentamicin can be administered under local anesthesia, a transtympanic injection, or via a grommet to the affected ear, thereby sparing toxicity to the unaffected ear in unilateral disease or to the inactive ear in bilateral disease. Surgical options are classified into destructive and non-destructive. Non-destructive procedures preserve the auditory function. Non-destructive options include endolymphatic sac decompression, selective vestibular neurectomy, tenotomy of the tense tympani and stapedial muscle tendons, and semicircular canal occlusion. Surgical labyrinthectomy is completely destructive to the labyrinth and is indicated only in patients with established non-serviceable hearing loss and persistent recurrent vertigo attacks. Decompression of the endolymphatic sac involves reducing pressure in this space. It is considered a conservative procedure because of the low rate of hearing loss and the high success rates of around 80% or more of vertigo control. The surgical method of endolymphatic sac decompression and drainage of the endolymphatic duct involves a broad exposure of the mastoid cortex, canal wall up mastoidectomy, and extensive removal of the pre-sigmoidal and retro-labyrinthine cells. A small aperture is created in the endolymphatic sac with a paracentesis blade or a scalpel. To keep the opening intact, a T-shaped celastic sheet or a T-tube is used, and an endolymphatic shunt can also be placed in the mastoid. Selective vestibular neurectomy is a surgical technique that involves a selective section of the vestibular nerve to induce vertigo with preservation of the facial and cochlear nerves. It can be used as an alternative to intratympanic injection of gentamicin to produce vestibular areflexia. Different approaches can be used for vestibular neurectomy. We've got translabyrinthine, middle cranial fossa, retrolabyrinthine, retrosigmoid or suboccipital, and combined retrolabyrinthine and retrosigmoid. The translabyrinthine approach may be considered as the only approach that does not need a neurosurgeon, and while the middle cranial fossa approach is a neurosurgical approach. Published case control studies report a similar or better outcome to intratympanic injection of gentamicin. The suggested mechanism of action in Meniere's disease patients is that the tympanic membrane is sometimes pushed laterally by increased cochlear pressure against the ossicular chain. And by sectioning the tensor tympani muscle tendon and or the stapedial muscle tendon, this effect is partially reduced. So far, conflicting results have been reported in the literature on tenotomy of tensor tympani and stapedial muscle tendons, and multiple studies have shown no statistically significant differences between tenotomy and intratympanic injection of gentamicin. Semicircular canal occlusion is a relatively new surgical treatment, and several case series have shown that semicircular canal occlusion is effective in the treatment of intractable Meniere's disease. The surgical technique involves making a fenestration on the semicircular canal, and occlusion over a short segment is achieved with a piece of soft tissue and bone wax. All three semicircular canals are blocked concurrently with the aim to block the movement of lymph in the semicircular canal so as to eliminate vertigo caused by postural changes. The principle is that after the endolymphatic flow is blocked, rotational vertigo caused by displacement of the ampullary crest is eliminated. Surgical labyrinthectomy can decrease vertigo by the total destruction of the labyrinth, but it leads to total hearing loss in the operated ear. It can be performed either via a transcanal approach or via a transmastoid approach. The surgical technique involves opening the semicircular canals up to the endolymphatic duct opening in the vestibule with complete destruction of the neuroepithelium and Scarpa's ganglion. Surgical labyrinthectomy of the affected labyrinth always ends in total deafness. Therefore, it should be reserved for patients with non-functional hearing and should be one of the last therapeutic options. Vestibular rehabilitation refers to a wide range of physical exercises and maneuvers that are intended to promote recovery of function and mitigation of symptoms related to balance disorders. The goal of vestibular rehabilitation is to reduce balance-related symptoms while improving postural stability and daily functioning. And by combining active head movements with integration of other sensory information, vestibular rehabilitation induces central vestibular compensation and habituation to alleviate the symptoms of chronic balance disorders. Vestibular rehabilitation can be proposed in patients with Meniere's disease with an established vestibular deficit to facilitate vestibular compensation. However, in the initial years of the disease, its usefulness is controversial. Audiological rehabilitation. So hearing loss in Meniere's disease presents a fluctuating course, and the adaptation of hearing aids is difficult in the early stages of disease. The use of hearing aids is recommended to improve hearing loss and to relieve tinnitus. In the most advanced stages, a cochlear implant can be performed, and uncontrolled studies have shown that cochlear implants in Meniere's disease can improve hearing, tinnitus, and vestibular function. Tinnitus can be a particularly distressing symptom, and management strategies include education, sound therapy, short-term drug therapy with benzodiazepines or sedating antidepressants, tinnitus retraining therapy, and cognitive behavioral therapy. These were my references. Thank you. We'll now take any comments or questions.
Hi, I just wanted to know if I can just make a quick comment. The problem I find with Meniere's disease, particularly in general practice, is that particularly if you're going to inject gentamicin into the ear, is are you injecting it into the correct ear? Because sometimes the disease can be bilateral. And if you inject gentamicin into the wrong ear, you've got a real problem on your hands. You know, the patient's going to become extremely off balance. So I really think that if you're going to be doing that, you need to really know what you're doing, and you need to have done all the vestibular tests beforehand. And I normally would sort of, I usually don't go beyond the point of injecting cortisone into the ear via grommet, and then I'll refer to a patient who deals with only otology or who likes to deal with this problem. So that's my feeling about it. You know, sometimes very difficult to decide which is the correct ear to operate on.
Are you unmute? Are you
Okay. Yes, thank you for your comment. Dr. Harris, can you please comment on?
Yeah. So, I mean, I agree. I think it is bilateral Meniere's, and it is very difficult. And the problem with that is that even with vestibular tests, it's difficult to identify what the offending ear is, because you've got vestibular hyperfunction bilaterally, and so you're not necessarily sure which is the ear that's actually triggering. Is it one? Is it both? Are they kind of fluctuating between the two ears? So that is very difficult. I must admit, I've not personally seen bilateral Meniere's because I've not been involved in the vestibular clinic for many years. But I think the American guidelines have got quite a nice sort of stepwise approach. And just to comment about your presentation, so a large part of that diagnosis is made on history. I'm talking about unilateral disease now. So do you send them with vestibular tests or not? And I think if you look at the American Academy guidelines, a lot of these patients are not necessarily in the very early stages of the disease. You go on the history and a very typical audiogram, which is low frequency hearing loss. So not all those patients necessarily are sent for vestibular tests. That's the first thing. And then the second thing is, do you image or not? Now, we've always imaged patients with MRI in the case of unilateral Meniere's disease where there's asymmetry, because we are taught that there's asymmetrical hearing loss. There are small portion of patients who will present with Meniere-like symptoms if they've got vestibular schwannoma, but it's a very small percentage. I've not changed practice based on the American guidelines myself, but it's just something to be aware of if you are seeing a patient who's on a medical aid, who's having to pop up 15,000 rand for an MRI, and that, it's not necessarily standard procedure. That's the one thing. And then the other thing is, I think we've also largely forgotten the stepwise approach in terms of lifestyle modifications, diuretics, etc. So it's very important on history to find out the frequency of the attacks. And I think in your presentation, and maybe this has changed because it's a long time since I've looked at it. And I don't do blood tests for all the patients. I'm not going to go and do an ESR and a CRP and an autoimmune screen and in the patients who've got typical audio. So the blood tests I would reserve for an atypical patient, a patient with atypical symptoms that we used to previously refer as Meniere syndrome rather than the Meniere's disease, where I'm suspecting that it's possibly an autoimmune inner ear disease or something else. I would then go and do blood tests. But I certainly don't order blood tests on your run-of-the-mill typical low-frequency triad patients. We don't do any of the sham procedures here. I think my go-to is still be if they haven't responded to lifestyle modifications, or if the severity of the attacks is such that they need intervention urgently, then the transtympanic steroids are still my go-to. And the last time I looked at the literature, in about 70% of patients, this was fairly successful. And then about 30% of patients either need a second injection, or you need to try either, you need to go to gentamicin. I've not needed to go to gentamicin myself, but that's just because probably I haven't seen, that many. I've not been involved in the vestibular clinic that much. And then the other thing is also to differentiate those patients who've got symptoms of vestibular hypofunction. So they've got Meniere's, it's kind of in the burnt out phase. They haven't compensated in terms of the vestibular function. So they're off balance. Those patients, you're not going to go and do gentamicin. It's not a typical Meniere's attack. These are patients who are just uncompensated and they need to be referred for vestibular rehab.
Thank you, Prof. Faris. Do you have any more comments from the floor or any questions?
Yes, I would like to comment on the gentamicin. I think now literature is supporting the use of low dose gentamicin, so around 20-25 milligrams, and we are moving away from the high dose gentamicin, this Project F protocol that was being done before, where you are giving 80 milligrams every week. So now you give low dose gentamicin, you titrate it, and you see how the patient is responding. But most of the time, it's considered like a last option. You do the medical, lifestyle modifications, medical treatment, the intratympanic steroids. The problem with intratympanic steroids is that the recurrence of Meniere's after about a year or two, they may be symptomatic again. But like what Dr. Harris said, it's effectively 60 to 70% of the population. But if it fails, then you need to reconsider your diagnosis. Sometimes are you dealing with the actual Meniere's? It's the problem of bilateral Meniere's. Do you have vestibular paroxysmia or vestibular schwannomas? And when you are doing the injections, especially the gentamicin injections initially, if they are not successful, again you need to consider a diagnosis. And sometimes you need to consider if there are adhesions around window, where you need to go into the theater and remove the adhesions. But low gentamicin injections has been shown to be effective and saves hearing over.
If you can ask, would you start the injection before you image? Once you go to that step, or would you still be happy just to go on the history and will you on the features and injection?
I would still be happy just to go on the history and
That's fine.
Thank you, Prof. Do you have any more comments or questions? All right. Thank you everyone for attending our meeting this morning. Remind everyone that we won't be having a meeting this coming Friday. Our next meeting will be next Wednesday. So we wish you all well and have a nice day. Goodbye.
Thank you, well done. It's